All right. Welcome everyone. Happy Friday. We are recording. This presentation will be added to our PFCC Partners YouTube channel, as well as there will be a live transcript available as well. As I mentioned, I am Naomi Williams, your patient and family engagement specialist with PFCC Partners. You can see our mission, vision, and values here on the slide. And this is what we at PFCC Partners is all about. We want to see a health system transformed into one that works for people and through communities as partners in their well-being. We catalyze the system improvements by centering that human experience of health. We absolutely recognize the critical role that community engagement must play for every effort at delivering health equity. I'm going to ask if everyone can just mute for just a moment, please.
Yeah, I know.
Lindsay, are you able to help me with the mute?
Yep, working on.
Thank you. So we know that the healthcare system is very complex. There are a lot of people, hundreds of different agencies and organizations, and a lot of dollars that pull up the healthcare system. And that complexity of this system makes it difficult for people to access the care that aligns with their needs, their health priorities, and their preferences. So we believe that in order for this to work well, it would be great to have a system that centers care and those care processes on the person and the potential that it has to reduce those complexities, as well as advancing a culturally humble and equitable healthcare system. So what does this mean and how do we do it? I'm so glad that you asked. PFCC Partners, we recognize the need to have an open space for patients, for family caregivers and community voices to drive improvements in this complex system. We know that these voices are a huge catalyst for the improvements and in that system change. So our team has decades of passionate experience in partnering with the healthcare systems and leaders that engage those with lived experiences to improve the efforts. We're open to creating partnerships that allow for improvement. One of the ways that we do this is through our PFA network. The PFA network is a community by patient family advisors for patient and family advisors. It's a network where people are using their lived experiences to influence healthcare improvement. The PFA network, we have engagement opportunities, we have community, we develop community, as well as we have skills development, where individuals with lived experiences are able to come and learn additional skills of how to become an impactful and effective partner for the change that they want to see. So without further ado, we're super excited to have, and I have the pleasure of introducing Barbara Lewis, who will be presenting and talking through where's the value in PFACs, getting proof with metrics. Barbara?
Thank you so much, Naomi. And if you can give me screen sharing, I will go ahead and share my screen. Thank you. Can you, yes, okay, everyone can see my screen, hopefully. So thank you very much for inviting me here to present on a topic that is so close to my heart. Where's the value for patient and family advisory councils? Get the proof with metrics. And I'm going to just tell you a little bit about why I'm here and how I got here. I started my career as a journalist. I wrote for national publications, including the Wall Street Journal, Ladies' Home Journal, and more recently for Modern Healthcare and British Medical Journal. I founded a marketing company for professional service firms. And then in 2012, I spent 2 weeks in the ICU with my sister, who passed away very tragically. A number of mistakes were made that the hospital system admitted to me later. And I decided to write a document called Joan's Family Bill of Rights that I sent to the head of the ICU about Joan's and my experience. And she told me she cried when she read it. She passed it along to the head of the health system, and they flew me across the country to make 3 presentations at their facilities. And while I was honored to give my sister a voice, I was absolutely shocked at the number of people who were lined up after each presentation to tell me about their experiences. And I thought, oh my gosh, this is not a personal story. This is really a universal narrative. So I closed my marketing company and decided to spend the rest of my life, and God willing, it'll be a lot of years, improving the patient experience. So the first thing that I wanted to do was to find out, where's the patient voice? And that was because I had made a couple of suggestions on medication and equipment to the nurses and the doctors, and was just totally dismissed. Nobody was listening to me. And come to find out, the medication was wrong and the equipment had broken. And so I was curious, where is the patient voice in this? And I wanted to find out more about it. So I started investigating, and I became the co-chair, the first co-chair actually, of the Barrel Institute's Global Patient Family Advisory Board. I was the co-chair of the Kaiser Permanente Southern California Regional Patient Advisory Council, representing 4.5 million members. And I'm currently pursuing a PhD in public health, and I'm studying patient and family advisory councils. So let's find out a little bit about you. And Naomi is going to launch a poll. So can you tell me if you're an advisor, but you're not on a pediatric family advisory council? And if you're on the hospital or institutional side? And then finally, if you're a patient and family advisory council member as a patient. And Naomi, have you launched that poll?
I have
Yes,
it.
it's going.
It is going. Okay, I can't see it, I guess.
We have about 65%.
Okay. All right. Well, let's not spend too much time. So
Oh,
go
sorry.
ahead and show us the results. So just so I can get an idea of where everybody is from here.
And I will say, if you aren't able to put your answer into the poll, you could put that in the chat if you haven't already.
Oh, okay. Here it is. Yeah, I see it. Okay. Oh, all right. So we have mostly hospitals and institutions. Okay, that's great. All right, excellent. And okay, so let me move on here. Thank you very much for filling that out. So the agenda today that I'm going to cover is, why do we bother measuring? And what are the steps for measurement? What types of measurement are there? How much should we measure? How long should we measure? How often should we measure? How do we display the results so that it's a compelling story? And I'm going to pause periodically and ask if you have any questions. So about 9 questions have come in already when you registered, and I'm going to answer those, most of them during the presentation, but a few of them don't have to do with this presentation, but I happen to just have given a talk in Boston at the Patient Experience Symposium on Tuesday, talking about best practices for PFACs. And I did answer some of your questions during that. So I'm going to bring up a couple of slides at the end and just talk to you so that I get all your questions answered. Meanwhile, if you have any questions, please put them in the chat, because as I mentioned, I will be pausing periodically for questions. And if I'm looking to the side, it's because I'm very fortunate to have 3 monitors, so I can keep track of the chat and my presentation and everything else that's going on. So let's just talk about 2 things on data collection. And that is that there's 2 types, and you may remember this from your studies, but there are quantitative data, which is numbers, and there are qualitative data, which are words. So one is numbers and one is words. And basically today, what I'm going to be talking about is the quantitative, the numbers, but I will touch on qualitative as well, because they're both very important. And the fact of the matter is, it's not always easy on a PFAC to get quantitative data and see an outcome or do pre and post measurement, for example. So I did some research in 2014. I was on a conference call, that was before Zoom, and the woman said that her CEO wouldn't start a PFAC unless there was a business case. So I had an MBA and I'd done a number of business cases, written them up before, and I said, oh, I'll knock this off in a few weeks. Well, 6 months later, I was still working on it. I did 2 surveys, one in March and one in November, and there were a little over 300 people participated on that survey. The results of it was that PFACs save hospitals money, they improve safety, and they enhance the patient experience. But I was very surprised that 3 PFACs had actually closed. I was horrified. I thought, oh my gosh, here I am trying to embed the patient voice, and now I find out that 3 PFACs actually closed. And by the way, this research is published by the Barrel Institute. It's called PFACs, Where's the Money? The Financial Impact on Hospitals. And that is free now. It's also on my website, Jones Family Bill of Rights. So you can find the results of that research. And a lot of that research is still relevant today, even though it was done almost 10 years ago. And my PhD, I'm hoping to update that research. Okay, so let me ask the question and put in the chat why you think that 3 of the PFACs were eliminated. Each of the 3 hospitals eliminated their PFACs. I immediately contacted them and I said, why? And all 3 had the same answer. So what do we have in the chat? Okay. Yes, so we have a couple of winners. It was a new CEO. And this was shocking to me. I thought, why in the world would a new CEO actually cause a PFAC to be eliminated? And then I started thinking about this and I said, okay, the new CEO comes into the hospital and they say, what's a PFAC? And what does it do? And there was no proof. There was no reports. There was nothing to prove the value to these new CEOs of why they should continue to have a PFAC. And so I've been on this kick or journey, I should say, to help PFACs measure and prove their value. Okay, so Naomi's going to launch another poll here and answer this question. Do your metrics, do you do this all the time with metrics? Never, always, or you don't know? And this is what happened in 2014 when I did the survey. And I was pretty surprised that only 5% of PFACs actually measure always or always measure. So let's see, I think that's good enough. Oh, do you measure, does your PFAC measure sometimes, never, always, or don't know? Naomi, can you release the results? Okay, so the majority is sometimes, but between sometimes and never, it's 75%. Okay, sometimes and never is 75%. And that's actually a little bit less than here, but not too much difference. Okay, so let's move on then. Talk about why we should measure. We measure to determine where you are and how far you want to go. So let's talk about wait times in the department as just an example. So you might have heard griping about the wait times, and so they're averaging maybe 30 minutes. And what do you want to do? You want to get it down to something that's at least a national average, maybe better. It's not more than 10 or 15 minutes, for example. And you have confirmed that there's anecdotes. Maybe people on the PFAC have talked about how long they're waiting to see a doctor once they check in with the receptionist. And then you want to see the data, which actually is now going to speak volumes. And I'm going to talk to you about different ways that you can display the data. You can quantify the costs, although this is often hard for a PFAC to do, but you can. So let's say that people are sitting in the waiting room and they just get tired of waiting and they have another appointment or they have a meeting or something and they have to leave. So these people end up walking out without being seen. So there might be a certain percentage of patients who walk away. So you can actually quantify those costs. And the whole idea is to reduce it. Reduce the wait time. So let me stop here and ask if there's any questions to this point. Anybody have any questions about why we're measuring or anything we've talked about so far? Okay, so why don't you put either in the chat or you can open your mic if you want and tell me about what it is that you want to measure. Give me some ideas of what you want to measure. And let me open the chat and see what's coming in here.
Do you want to measure the number of complaints?
The number of complaints, okay. And obviously you want that to go down, right? The number of complaints. So that's really good. You can take a look at the complaints, what they're around, and figure out what to do. So at this conference, one of the speakers was talking about the fact that he had this research and it said that there was a problem with the surgeon. The surgeon was rude. There was no communication, didn't speak. And he said, you know, if this was over a 3-month period and it was all the surgeons, that'd be one thing. But it was over a couple of weeks if they had analyzed and it was one particular surgeon. So that surgeon obviously needs some re-education, as they say, not using remediation. So let me take a look at what you're doing.
Barbara, real quick,
Yeah.
I see Billy's hand is up. Billy
Oh, okay.
Adler.
Oh, Billy, yes, go ahead.
Wade, if you want to jump into that.
No, go ahead. What did you want to say? This is an interactive
So
conversation.
I came across a great PowerPoint at one point in time, a while ago. I don't have it at my fingertips, about how a particular PFAC was able to impact their health system's HCAP scores.
Mm-hmm. And how did they do that? Oh, was that what, but did an organization put that out? Did they do the research?
Yeah.
Yeah.
It wasn't a paper. And forgive me because it's not clear in my mind right now, but at the time I was like, wow, like that's a big lift. And I just am curious whether or not you have any information and or experience relative to the opportunity to do that, or if you know of any PFACs that have quantitative information that might reflect improvement in scores.
I don't know specifically anybody who has tackled that, but you know, the 10 dimensions are quiet at night. The 2 dimensions that drive the scores are the communication with the nurses and the communication with the doctors. Discharge is one of them. So, you know, if one was low, if a particular score was low, then the PFAC could actually tackle that. Let's say on discharge, are the instructions good? You know, is it done in several ways? Is it writing?
Mm-hmm.
Is it written? Is it a video that you can watch? Is there a call number when you get home and you're getting out and you can't think of what you should be asking? So they can certainly be brought to the PFAC. I don't know about lifting the entire score, but certainly lifting specific scores one at a time could be very plausible.
Thank you. I mean, Quiet at Night is actually a patient and family-centered care initiative at UMass this past couple of years, and our PFAC members participated in that. But our medical center PFAC, which is the main PFAC, is very interested in discharge. So I appreciate that input.
Sure. And I see that there's some discharge here and a lot of things that you want. Education of medications and side effects. So actually Georgia Regents had mistakes in their medication. I think it was about 60%. And the PFAC talked about the directions for that, and they were able to decrease those mistakes in taking the medicine bring it down quite low. Okay, the most important reason, you all know what I found out is that the CEOs change and that PFACs may be eliminated, and you don't want your PFAC eliminated because you haven't measured anything. Okay, so let's talk about the proof of concept and the different types of measurement. And this is developed by the Agency for Healthcare Research and Quality, otherwise known as AHRQ. So there's 3 types of measurement that they define. And one of them is process. And this is basically what the PFACs fall into in measurement. The number of meetings that we had, the number of projects that we did, the number of people that are on the PFAC, the number of recruitments that we did. And that's fine, but it's not really an outcome measure. It's not giving you the value of it. It's a process measurement. The second one is structure, and that has to do with capacity. So for example, in our wait time that we're doing, we were able to reduce wait time by 50% or whatever the case may be. And this is difficult. Structure is difficult for PFACs to do. But the third one is outcome, and this is known as the gold standard or the best type of measurement that you could be using. So this is pre-post. So we're measuring the waiting time before the intervention, and we're measuring the time after the intervention, for example. And then another example may be cancellations that are decreased by the directions are hard. So let's say we're talking about colonoscopy and people get to the reception and the receptionist goes through all the directions and the person said, oh no, I forgot to do that. And then they have to leave. So there's cost associated with that. So the directions go to the PFAC, they're rewritten. And now those cancellations are decreased by, let's say, 50% or something. It's very important to create an annual report for your executives on your accomplishments. And I know I had one question here about getting the C-suite hospital personnel to listen. So one step in that direction is by creating this annual report. So what should you measure? All right, everything should be measured. Now remember, there's 2 ways of measuring. One is by the quantitative, which is basically what I'm focusing on, but I'm also going to touch on the qualitative. So you can measure on qualitative as well. Okay, the Massachusetts story. And I did have a question. Is Massachusetts the only state that is mandated? Yes, it is. So down here, these are the percentage of hospitals that have PFACs by state, and it's hard to see, but let me go all the way over here to the right side, and that is Oklahoma and Wyoming have only 23% of their hospitals have a PFAC. Now you come over here to the left side, and DC, Massachusetts, and Rhode Island have 100% of their PFACs, 100% of their hospitals have PFACs. Now, this is from American Hospital Association data, and I want to thank them for giving me this data. This is subscription data, but because I'm working on a dissertation, they gave me a lot of data that I was able to analyze. And this is the responses. So this isn't all hospitals. This is just the people who responded to that particular question. Since 2018, that question has been on the annual AHA survey. And that is, do you have a patient family advisory council that meets on a regular basis? So Massachusetts actually has a mandate for it. It was passed in 2008, and all hospitals had to establish a PFAC by October 1st of 2010. They're required to write an annual report on the impact that is available on request as if the public calls and requests it. However, the organization that actually shepherded this through as a law, Healthcare for All, is the consumer advocacy organization. They collect the reports and they publish them on their website. So it's a 12-page form, and there's 3 questions that have to do with impact and accomplishment. One is providing feedback or perspective. The second is influencing the institution's financial and programmatic decisions. And the third is leading or co-leading programs and initiatives. So I did this analysis in 2 years. I actually did it in 2014 and also in November of last year. And by November, and this is due in October, but by November, 24 hospitals of the 82 or 3 hospitals in Massachusetts had submitted their reports with 112 accomplishments or impacts. So there were no outcome measures. It was all process measures. Examples: participated in PFAC meetings and interacted with other PFAC members, instituted unconscious bias training. But one hospital did say what they wanted to do was they wanted to better delineate specific outcomes from advisor participation, such as improving tracking methods and evaluating various strategies. So there's basically 3 questions that you want to ask. What are you trying to accomplish? How do you know change is improvement? And what change can you make? So I'm going to give you an example, and it's actually not with a healthcare. It was something that I learned in business school, but I thought it was quite interesting. And this is the fact that when the car dealership lined up their cars, they noticed to sell them, they noticed that the red cars were all different shades of red. So they went to the manufacturing company and they said, and this is one of the big 3 car manufacturers, they said, we want the red color, we want all cars the same red color. They have different tones to them. So the manufacturing company looked into it, and because of the way that paint is manufactured, it could have different variations depending upon where it's sourced from. And they said, yes, we can do this, but if we do it, you can add $200 to the cost of a car for anyone who buys a red car. And so it was an improvement in that if they lined the cars up together, they would have all been the same red, but the dealership decided, no, it wasn't that important. And what they started doing is actually having a red car next to a white car and then across the lot somewhere else, so that the red cars were never next to each other and people could tell that there was a slight difference. So now let's talk about the steps for measurement. So you're going to decide what you're going to measure. And I'm going to stop right after this and ask if there's any questions. So if you have anything at this point, please write them in the chat and Naomi will keep track. Then you want to establish the parameters. Okay, so if we're doing the waiting time in the room, is it when they come in the room and they start standing in line, is that considered wait time? Is the parameter that when they get to the receptionist and they say that they're here, they're checking in, that's the beginning of the time? So you need to set the parameters of exactly what you're going to measure. Then you're going to determine the metric. So are we observing people and we're timing them as they come in with a stopwatch of when they got to the receptionist and when they sat down and then when they went in the room? Or can we do that with the electronic health records so that the receptionist has them checked in, that has a time stamp on it, and when the nurse takes their vitals, that has a time stamp on it also, and that's what we measure. So you want to determine what the metric is that you're actually going to use. Then you're going to gather the data, and we're measuring the baseline. So we're doing the before the intervention or before the activity that's going to hopefully change the measurement, analyze it, and then create a compelling story about people in the waiting room, one person who had to wait this long and they had a babysitter and they couldn't get back in time, a story around the wait time. And then you're going to intervene with whatever it is. And finally, you're going to repeat the measurement then after the intervention. Okay, there's a lot of steps on here for measurement. So are there any questions or comments about the steps for measurement?
Her hand up. Maria Fernandez.
Yeah, so a lot of these are, so we do a lot of lean work at where I work.
You
And
do a
so
lot
this
of
is
what kind of work?
lean
Lean,
management.
okay, lean,
Yeah, process improvement so this is obviously part of that whole thing, but
Yeah.
a PFAC alone does not have the ability to create the intervention. So
Well,
so I'm just wondering, how we're dovetailing that into this conversation.
Okay,
In
so
terms of being able-
go ahead. Okay, so PFACs have on as members the patients and families, but they also have liaisons. Most of them have. I mean, I know one hospital system that doesn't have liaisons, but then they speak to the liaisons after the meeting. And that's because they have so many PFACs in the organization. But so those liaisons are the ones that would be going back to leaders or going back to the department and developing the intervention based on what they heard from the PFAC. The other thing is the department that maybe has a long wait line comes to the PFAC and says, we've got to do something about this. Can you help us? And in this particular case, let me just throw in here that the wait time actually is perception, because studies have shown that if there's some type of intervention, if it's the TV is going with educational videos, or if there are Sudoku puzzles or things like that for people to do, their perception of the wait time is very different from the actual wait time, and that's research based. So the intervention could be as small as putting in some puzzles with a pencil next to it that people are doing, and their perception of the wait time actually changes.
Barbara, a follow-up with that. One of the questions is, who is the liaison?
Oh, okay.
Is
So
that the administrator or someone else? Somebody
So
else?
these are the people that work for the hospital that sit on the PFAC. So it should be a leader, hopefully an MD, or it could be an RN, and then it could be admin people who are there to help with administration type of work that attend. And hopefully people have leaders that are sitting on their PFACs.
Can I just
Karen,
ask a question? I'm sorry, just about that, just because we have struggled with this for years, and just to dovetail. So what then you're suggesting is that the PFAC, and let's say the Patient and Family Centered Care Department, is then reliant upon others to implement the changes and do the measurement. But where we struggle is what can we within the PFAC, just ourselves and the people on the PFAC and the manager for patient and family centered care, what can we measure on our own that does not rely on others to go out and implement in our organization?
So it depends on what you're trying to change or what you're trying to do. Some you will be able to measure, and some you definitely won't be able to measure. You're going to need the departments or need the statistics from the hospital or whatever the case may be. Now, if you have a hospital that is backing the PFAC and very supportive, that should be easy to do. If you're in a hospital where it's like arm's length away and, they're in a room and we're going to give them donuts and then that'll be the end of it, then that's going to be difficult. Now, I have a wiki that's called, and I'm going to give you the link to it. It's called Starting and Sustaining Patient Advisory Council, from leadership assessment to something else. And in that is leadership assessment. And it's actually an algorithm where you put down, you score what your leaders are doing, and then you add up the score. And if you've got a certain score, you shouldn't start a PFAC yet because you don't have the support that you need. You need to garner more support. So you may want to, I've designed that to help organizations decide whether or not they should start a PFAC. But actually, you could use it right now to see if you've got the support that you need to be as effective as you could be. So that's, it depends type of a question, I think.
I see
Okay.
Karen Fernandez has her hand up as well.
Okay, go ahead, Karen.
Thank you. As we're talking about data measurement and so forth, you had mentioned the electronic medical record, the EMR. And if we outline that as the data collection tool, whether it's registration and the BP being taken, You're going to have, I think, better data than if they're going to do a checklist. As much as we can use the EMR, it would be really beneficial and you'll get more hospital buy-in.
Yes, absolutely, I agree. Yeah, but the hospital has to agree to let the liaisons to access that data and analyze it. And of course, some hospitals have whole departments that are just devoted to analyzation. So, you know, you say, here's what we want to do, and we want to help the hospital save money, improve safety, or enhance the patient experience. I mean, those were the three things that I found that PFACs can do when I did the research in 2014.
One other thing, and I had put a comment in the chat. Right now, there are no Joint Commission standards that require this. There are no Medicare conditions of participation that require it. However,
Require what? Require what?
Having a
PFACs?
PFAC.
Yeah, the Joint Commission does ask.
There's no standard. There's no element of performance.
Okay, actually, I'm talking to the Joint Commission about what they are doing because I'm curious to find out what they're doing.
Yeah, I'm on their consultants forum.
Oh, you are? Okay.
Yeah.
So you know.
And another thing that is changing, which may help our perspective, is they have just purchased the National Quality Forum.
Yes.
The National Quality Forum has patient family section, so that may give us more power with the Joint Commission to establish the standard and or element of performance for them to be surveyed to.
Right.
Then CMS could put out a letter to the field, because right now the COPs are very difficult to change because they have to go through Congress. But if they put out letters to the field with specific requirements, then that would fall under the governing body that also may assist our work in this.
Right. Okay, well, keep up the good work, Karen. We need it. Okay, now let's take a look at how much data. You know, there's the time. It can be 1 month, 1 week, or 3 years. It can be a statistical sample, but it should be enough data to prove your case. So you can measure a lot of different ways, and here are just some of them. You can survey, you can use electronic data, you can time something, look at the amount, the cost, observe, or let's say the number of people who are in the waiting room at one particular time, for example. So displaying the data is important, and I recently saw a presentation on displaying the data, and I wanted to share this with you. So you can do a run chart over time. You know, this is February through December. This is the quantity, might be the number of people that can't get access or whatever the case may be. It can be a bar or a line graph. This is from the AHA data. So 35% of all hospitals who responded to the survey who have between 6 and 24 beds have a PFAC. Up to 500 or more beds, 81% of them have a PFAC. You can do a thermometer, which we've all seen, you color in, and you know, oftentimes this is raising money, a pie chart. So only 55% of hospitals in the US have a PFAC that they answered on the AHA survey. And PFACs have been around since 1982. That's the first one that I found, and that was the Boston Children's Hospital. And we haven't come very far, so please continue to work in this area. And finally, a scattergram. So this is interesting. So 1960 is the blues, and 2016 is the yellows. It's the fertility rate mapped against the life expectancy. So as you get older, the life by decades, the fertility rate has been decreasing. So the data display should tell a story. And I'm going to just go through this very fast. This is the display of data for the Challenger shuttle that launched in January 1986. This is what the engineers used. You remember that was not a successful launch. It actually blew up because of the O-rings. So they displayed the data as rockets and the temperature, and it was in chronological order. So here's 24 launches, and they're talking about the temperature outside when they launched, mostly from Florida, and what happened. And these are failures. So you really can't tell anything good from this data. But now when you look at it like this, with the degrees up to 85 degrees and the damage of the O-ring, you can see these down here were, and this is what the temperature was in Florida that day. All launches below 66 degrees had an O-ring failure. So if those engineers had seen this data and saw that the temperature was so low, that Challenger would have never launched. So they really didn't communicate what they were trying to see, because there was no relationship between the O-ring failure and the temperature. So we hope that we could have before and after statistics. But what if there is no measurement? What if we don't have a way to measure in the quantitative ways that I have discussed today? So you can survey the department for feedback on qualitative data. So one organization does this, and after everyone comes in to talk to the PFAC about what they want to do, then they send them a survey and ask them what they got out of it, if there could be an improvement in the process. They have very comprehensive process that is before the meeting, during the meeting, and after the meeting. So they survey it. And out of this survey has come fantastic quotes. We walked in with knew what we were going to do, but after we heard the feedback, we changed 180 degrees and completely changed our program. So asking things like, what were the top 3 most meaningful pieces of information that you got from the PFAC, and any suggestions for improving your PFAC encounter, and then any other comments. So every single encounter that you have with a department that comes to speak to you about what they want to do should have a after survey, a post survey, where you get information about what they got out of it. So here's an example. This is both quantitative and qualitative. So the pre-planning meeting, rated on a scale of 1 to 5. And then in a few words. So something like this is just an example of the post-meeting survey. And I just mentioned the 180 degree change with the survey.
And you are going to be safer.
Okay, so let me get you some recommendations and then get to the questions that were asked that didn't have to do with metrics, and this was on registration when you asked. So number 1, measure every project and do it either quantitatively if you can, because that holds a lot of weight, or qualitatively if you can't do a quantitative. Log the results. Always keep track of who visits you and what the results are, so that at the end of the year, you have an annual report about your accomplishments. So here's who came, here's what they discussed, here's the suggestions that we made, and here's the results of what the person said when they left. So I'm going to answer some questions that are not related to this about several topics that I thought were quite interesting. So number 1 is recruitment. And here are a dozen ways that you can recruit. So one of the most common ways is to look at the comments, the narrative comments that come in on surveys or the HCAPs, and then contact those people about being on the PFAC. Patients and family members who have either complimented and or complained about the hospital and the staff, they also
a bunch of stuff in this.
Make good members on the PFAC. Recommendations, if you have an ombudsman, maybe that person has heard complaints, and somebody who's vocal and who speaks up, whether it's a complaint or a compliment, they're probably going to be good on the PFAC, as long as they are not just focused on the one thing that happened to them. You want somebody with an open mind. A newsletter article requesting volunteers that might go to the community, for example, or to your patients, your members. Now, very few PFACs I have found have a website page where you can actually click on a page and it invites visitors to apply to go on the PFAC. That's another way that you can recruit. Having pamphlets in the departments where those old magazines used to be, a pamphlet explaining what the PFAC is and how you can join a PFAC with the application. Posters in the cafeteria. Messages in pharmacy bags, not an 8.5 by 11 by just a third of a piece of paper. Stick it in each pharmacy bag has been very successful for at least one hospital that I know of. This has been very successful for several public service announcements that go on television and talk about this, talk about the PFAC. So that has been very successful with some hospitals. Hospital volunteers. Now, I started a PFAC that had exclusively hospital volunteers on them. So they didn't have to do a lot of the background checks and the confidentiality and the TB shots, et cetera, because they had all been vetted already, the hospital volunteers. Of course, the problem with this is that they may not reflect the demographics, because we know that a lot of people who volunteer are retired and older. This hospital happened to cater to older people, though, so it was fine. But that's another place. Now, let me ask you, where are you finding your volunteers? You can go ahead and put that in the chat, and let's see. That's different from this. I've tried to include them all, but maybe there are others too. Is there anybody who has any other ways that you are recruiting? I don't see any coming in, so maybe this
There are some.
Oh, why aren't I
So
seeing?
community events, churches, synagogues,
Oh, right.
farmers markets.
Oh, excellent. Okay, good. Yeah, the farmers market on the premises. Yeah, that has yielded people that I know of. And if you're looking for the demographics, going out into the community to specific groups.
Was also mentioned outpatient clinics, sororities, and fraternities, which I think we don't tend to utilize or connect with.
Yeah, those are all good ideas. And especially if you want to mimic your demographics. So one of the first things that you have to do is to find out what are your demographics. I mean, basically you can know by walking around the hospital and going by various departments or something like that. But the hospital can give that to you, or what the demographics, and then those demographics should be reflected in the PFAC as well. Okay, so the next question that came in on the registration had to do with retaining PFAC members. So one thing that you can do is you can survey people to find out why they're leaving, often a business called an exit interview. And why they're leaving will give you a good idea of what you can do then as an intervention in the future. So one of the reasons may be moving, and there's really nothing that you can do. I mean, you can't force the PFAC members not to move, right? So that's not going to work. But there may be other things that, I'm not having an impact, or maybe I don't have the time, something like that. The most important thing is that you want the PFAC members to feel engaged. And let's talk about a few different ways to do that. So appreciate them. Are you paying for parking? Are you paying for babysitters? Are you giving them a stipend of a certain amount, maybe $25 to attend each meeting? Do you provide food and drinks for them? All of those are appreciative activities that help make the PFAC member feel important. Another thing is having that appreciation voiced by leaders. Do leaders come to the meetings, and do they thank the PFAC members for being there, that they really appreciate them? And the other thing that is critically important is one institution has a contract that if you come before the PFAC and you talk, you get their feedback as a focus group. So, PFACs are built-in focus groups. as you we talk to them and leave, and you have the impact or the suggestions, that you have to return to the PFAC between 2 to 6 months. So 2 months to give you enough time to implement the suggestions, but no longer than 6 months. And this is important because we oftentimes give these suggestions and the department or the hospital goes off and makes the changes, and we never know what happened. You know, and we're wondering, well, I wonder what happened to that thing that we suggested. So it's very important that the people come back and that they discuss what the impact was, specifically what they did based on what the PFAC members talked about. Okay, so I mentioned previously that the patient symposium in Boston, I spoke at on Tuesday. I talked about high-performing patient and family advisory councils, winning strategies and best practices. So this is what I suggested. This was actually one of the last slides, and this will cover a few of the questions that you had. You know, you need to demonstrate leadership support from the top and through the system leads, so that the leads are not just administrators, but hopefully they're MDs or nurses, and they have a passion for this. And there are many people who work on PFACs on the hospital side that are very passionate about the work. You know, commit to a co-design, nothing about patients without patients, so that departments are not coming to the PFAC and just getting that stamp of approval. Okay, we went there, they said okay, but that they are really co-designing from the bottom up. And this is quite important for patients to be involved with. As a matter of fact, one VP at an institution says that if somebody walks into his office and if they have a suggestion about an initiative that they want to start, he always asks where's the patient voice, because every initiative needs a patient if it's patient facing. And then create a comprehensive process for meetings, pre-meeting, during meeting, and post-meeting. And at this conference, I talked quite a bit about the process for having the pre-meeting, for the during meeting, and the post-meeting. And then train the leads and the members on measurement types, those 3 ARC types, the process, the structure, and the outcome. And encourage pre and post metrics on every project. And if it's not quantitative, then at least collect the qualitative data at the end of the encounter. Create an annual report for executives and share the results from the previous projects with the council so they know their impact of time and commitment. So I just talked about this, and very important to do. Okay, so here is a resource, and this is the wiki that I have, and I'm actually going to take it down and redo it. So if you're interested, you can get it here. It's a bit.ly right now, Start, Sustain, PFAC. It's a 54-page document, and I put it up probably in 2015 or so, so it definitely needs to be updated, but it's 54 pages, so it's got a lot of good information on it. And one of the questions was about the C-suite being able to listen. And I think this will give you some ideas on how to get them to listen. And if it doesn't work, if that's not good for you, if the PFAC, if this document doesn't have that, then you can take this survey. It's just two questions. It's for the hospital side. Do you have a PFAC? How many PFACs? And then if you're interested in talking with me for my dissertation, to put your name in. But I just added a question right before this about any comments or questions, so that you can at least contact me if you have a specific question about a PFAC. I know some PFACs are struggling, others are having a hard time launching. So, go ahead and, if you would, please take that survey. If you're on the hospital side, I really appreciate it, because I'm just trying to find out how many PFACs that hospitals have. And I think that is it. So let me open it up and see if there's I know there's been a lot going on. Okay. Oh, thank you for the compliments. I appreciate that. So anything that you see, Naomi, questions or anything in the last 4 minutes that we have here?
I haven't seen any additional questions come in. For those that are on the line with us, do you have any additional questions for Barbara?
Oh,
I have a
C-suite.
question.
I'm so sorry about the C-suite. Yeah, that's the CEO, the CNO, the CFO, the COO. Yeah, it's anything that is the chief. And now they have a chief patient experience officer, which is really good. I'm sorry, go ahead with your question.
So you recommended that recruitment happens everywhere and anywhere. And one thing that you said, those who are complaining and complimenting. I have found, I am the chair of the Patient Family Advisory Council for the last year and a couple of months at our children's hospital in Florida. But what I find is that if we recruit families who are complaining, they come in and that's all they want to do. And I read what somebody said on top, I think it was Maria Fernandez, maybe, that we have to be so intentional about our recruitment, because we often end up, when we recruit anybody who was just discharged and wasn't ready or had a lot of complaints, that they think our council is just a place to complain. And I know that we can moderate it, we can manage it, but that's what I found. It's kind of difficult for us to go to the, put an announcement and in a bulletin board, because we gotta be careful about assessing these families. So it's not as easy as, it can sound. We do have 37 members.
Okay, so let me tell you about how I deal with that. So it's hard because you have some people that are just on a roar. This is what this is what happened. I want to talk about this. This is it. And they have no concept of the agenda. So I don't invite people to go on to the PFAC. What I do is I position it as a meet and greet. And then the new member, or if you're starting a new PFAC, you get all of them together. And in one PFAC that I started, which was all new, I had somebody that just monopolized the conversation. So it was a meet and greet, and he was not invited back because he was just overbearing. He didn't give other people a chance to talk. So as you position it as a meet and greet, then you don't have to invite them, and you can see how they interact. And if they are speaking up, then one of the things, about one thing that happened to them or 10 things that happened to them that were wrong, then they need coaching. And coaching is critically important to make sure that members are performing the way that they should be. And that is interacting, not monopolizing the conversation, etc. And that was my whole presentation that I'd already did this week on best practices. But they should not be invited on right away. They should be
right. No, we don't
great.
invite them right away, but if when
And
they say
coach them.
Yeah, we do a lot of that, but it's very difficult to keep the complainers, because the complainers, that's all they want to focus on, and it's hard to get them to move. And of course we manage the conversations, and we but I just made it very difficult to put an ad somewhere, because we just don't know who's going to come in.
Okay, well, maybe I can give you some suggestions on either the coaching or the vetting, because they should not get on the board or the council and then monopolize. Okay, are we at time? I think we are. If I had my email up here. If you have any other questions, I have a bunch of resources that I can give to you. And oh, I guess you're not seeing my email anymore. But let me know, because I'll answer your questions, because this is my passion and it's close to my heart.
Thank you so much, Barbara, and everyone for joining us this Friday. This has been recorded, and again, we will have it on our YouTube channel. You will receive a follow-up email with the resources that Barbara mentioned as well. It will have her contact email as well as the bit.ly. I know Barbara, some had mentioned they tried to click on the bit.ly or check it out and it was not coming up. So if you're able to just double check that and see
Okay.
that it's a workable link. And other than that, we thank you all so much. Enjoy your weekend, be safe, have fun, and we'll see you the end of next month. Take care.
Thank you, everyone. Bye.
Bye.